So, and I am sorry that it didn't record. I can't put it on a presentation because it's trying to do the same timer, and I'm not sure that I'm as quick as I was when I was recording. Chrissy says she can't hear. Am I not loud enough?
Yes.
Yeah, we can barely hear her, Miss Gilbert.
Yeah. Her microphone is not very loud.
Is this better?
Make sure that y'all's volume is as high as it can go. Try again.
Is that better?
Is that better for y'all?
A little it, but it's still very faint.
Mm-hmm.
Yours is real. When I turn it up, I hear Miss Gilbert really loud, but not myself.
You try it without your headpiece.
Do you want me to try it without the headpiece?
Yeah, maybe it'll pick up better.
Well, let me try.
Might then have to change your microphone. Sorry.
Okay. No, I think they can't hear me at all without the headset.
Uh,
But I can talk louder. Is this better?
if you talk louder.
If I talk louder, that's better?
It seems so.
Okay. All right. I will try to do that. Okay, so welcome to Chapter 12. We're going to talk about the high-risk perinatal care and gestational conditions. And one of the main ones that we're going to talk about is hypertension. Hypertension in pregnancy, the significance and incidence here is that it's approximately 5 to 10% of all pregnancies. And hypertensive disorders of pregnancies are the most common medical complication reported during pregnancy is hypertension. And it is a significant contributor to maternal and perinatal morbidity and mortality. And I don't know if you guys are aware of this or not, but even in the state of Georgia, our maternal mortality rate is quite high in comparison to that of the nation. And a lot of it has to do with a lot of the comorbidities that are occurring during pregnancy. So some alarming statistics here. The CDC maternal mortality prevention, uh, it is such a problem in the nation that the CDC has gotten involved and brought about various um, programs to help to eliminate the maternal mortality situation, such as the Erase Maternal Mortality Surveillance to eliminate maternal mortality system. There's the Pregnancy Mortality Surveillance System, and then there's prevention of pregnancy related risk factors that occur that we're trying to uh, make sure that we're educating the public about the signs and symptoms of these comorbidities so that and making sure that everyone has adequate access to health care so that we can decrease that maternal mortality rate because this is 2020 and the rate is very close to what it would have been like in the 1960s. So this is what the data from that maternal mortality review information application, this is what it was a group or a committee that got together and they came back and they came back with these statistics and they said that approximately 1 in 3 deaths among women during or within a year of pregnancy were pregnancy related. They were pregnancy related. And pregnancy related deaths occurred during pregnancy, delivery, and even up to 1 year postpartum. So they count these deaths up to 1 year postpartum, and a lot of that had to do with eclampsia or seizures that were occurring because of preeclampsia during pregnancy. So the leading causes of pregnancy-related deaths, they do vary by race and ethnicity, and that is also because of insurance. It does have some to do with culture and just general access to healthcare, because there are a lot of very, very small rural hospitals within the United States that are closing for various reasons because they don't have the funding to remain open. And so they were very necessary in order to allow everybody to have access to health care. So there's 2 out of 3 deaths that were determined to even be preventable, and that is the point that we're trying to hone in on the education side, is by making sure that everybody is aware of the signs and symptoms and understands how to educate their patients concerning these comorbidities. Hypertension in pregnancy. There are some classifications. Now, everybody, if you will, I forgot to mention this earlier, but you have a workbook, and it's Maternal Child Nursing Care Workbook. It's a study guide, and this particular PowerPoint will go right along with that workbook. So if you pull out your workbook and turn to page 80, when you see a green term on the screen, then it correlates with the answer to one of the questions in the learning key items in your workbook. And I tried to put numbers out beside them too so that it would correlate with them, but as we go through, you'll see them on the PowerPoint. So again, it's page 80 in your workbook, and we'll cover page 80 all the way over to page 81 with the learning key terms. So the hypertension in pregnancy classifications, there are 4 basically. There's gestational hypertension, preeclampsia, eclampsia, chronic hypertension, and then preeclampsia superimposed on chronic hypertension. Hypertension, that's number 1 in your workbook, and the definition here is that it is a systolic blood pressure that's greater than 140 or a diastolic blood pressure that's greater than 90, recorded on 2 separate occasions at least 4 to 6 hours apart. And it's 4 to 6 hours apart to rule out the white coat hypertension phenomenon. So if we do it 4 to 6 hours apart, we know, hey, this person truly does have hypertension in that sense. And it's the same parameters that you see in the med-surg. It's 140 over 90. And then with gestational hypertension, which is number 2 in your workbook, it is an onset of hypertension without proteinuria after the 20th week of pregnancy. So the distinction here between just chronic hypertension and gestational hypertension is that gestational week of the 20th week of pregnancy. If it occurs before 20 weeks, we consider it chronic. Now, preeclampsia, which is number 3, this is a pregnancy-specific syndrome, and we'll explain it to you. So hypertension that develops after 20 weeks of gestation in a woman who was previously normotensive. So on her other prior records, she did not have any occurrence of hypertension. Okay, and it is actually a vasospastic systemic disorder that's characterized as either mild or severe. With severe preeclampsia, it's the presence of a blood pressure of like 160 over 110 or greater. And it also occurs on 2 or more occasions at least 4 hours apart. There are some other symptoms that go along with this that will reflect the multi-organ system involvement that's also present. And those other symptoms are proteinuria. They will have a decreased platelet count. They may have impaired liver function or renal insufficiency. They may have pulmonary edema and maybe even some visual disturbances to go along with the blood pressure that's 160 over 110. Now let's look at eclampsia, which is number 5. Eclampsia now is the actual seizure activity as or a coma in a woman who was diagnosed with preeclampsia. And this woman doesn't have any history of pre-existing pathology. She did not have seizures before. She did not have seizures during childhood. So these eclamptic seizures, they can actually occur during the antepartum period. Okay, that's when she's just pregnant and going back and forth to the doctor's office for her normal visits. Actually, during the intrapartum period, when she's actually in labor, or the postpartum period, and as we said before, several, even up to a year afterwards of that pregnancy, she can exhibit a seizure as a result of preeclampsia. So chronic hypertension and chronic hypertensive disorders is there actually the hypertension is present before birth, actually before pregnancy, excuse me, and the initial diagnosis may be during pregnancy because everybody is very vigilant during pregnancy and checking all parameters, and it lasting greater than 12 weeks after birth. So one of our criteria is to really hone in on that this is truly chronic hypertension. It's also how long does it last after birth. Does she have to have antihypertensive medications during the postpartum period? That's another indicator that it actually probably was chronic, because the cure for preeclampsia is the birth of the baby. So chronic hypertension with superimposed preeclampsia, now that's very dangerous. This is where she had chronic hypertension to begin with. She probably was on antihypertensive medications prior to pregnancy. Then when she became pregnant at 20 weeks, her symptoms exacerbated. And so then she had chronic hypertension with preeclampsia on top of chronic hypertension. And it's very difficult to diagnose this chronic hypertension with superimposed preeclampsia, but we can pretty much hone it down because it's associated with a lot of adverse outcomes. The person who's going to end up in the unit with a lot of complications typically will be the woman who had chronic hypertension with superimposed preeclampsia. Okay. Preeclampsia, the etiology of it. So what actually causes it? So signs and symptoms develop only during pregnancy and they disappear after birth. This is with the preeclampsia now. Only during pregnancy and they disappear after birth. But they are associated with a family history, multi-fetal pregnancy because there's 2 babies on board, a lot of stressors. African American race, typically there's a gene specifically for the African American race that in the geno that increases blood pressure. I used to know what it was by heart, but I forgot. And then obesity, and also if her age is before 19 or after 40, there the incidents are a lot higher. And then if she has pre-existing medical or genetic conditions such as diabetes, etc. Here's where we get into the pathophysiology. Okay, what actually is the pathophysiology of preeclampsia? First of all, if you see over here, you see that there's a picture of uterine arteries. Excuse me. And these uterine arteries are at the site of the placenta. Okay, so this is at the site of the placenta where these uterine arteries are going to pump the blood to the placenta so that the oxygen and the nutrients can, of course, be diffused or go by active transport into the fetal circulatory system. You'll notice that the early pregnancy here that this uterine artery is of normal diameter, as it should be, But we're developing these little cells called the extravillous trophoblastic cells, and they're going to attach here to the into the lining, okay, into the endothelium inside of that blood vessel. Once they do, they will start to uh, dilate those blood vessels or those uterine arteries every so often. And you see at the very end of the first trimester how they have started to dilate the uterine artery, and then the enlargement at the mid gestational period, how it's gaping here at the top. And then come towards the third trimester, it is such a gaping or large diameter that it no longer curves. It's just straight. It's like a huge gaping river here because at this point, she is transporting 400 cc's of blood per minute to that placenta. And that's also the reason it's such a risk of postpartum hemorrhage afterwards if we don't occlude those uterine arteries. Okay? Now, back over here. What happens to a person who has preeclampsia is that the vascular remodeling that occurs with those cells and causing the uterine arteries to increase in diameter does not occur. It doesn't occur in women who have preeclampsia. So therefore, the placenta tries to compensate for the lack of oxygen and the lack of nutrients that it receives by sending out a toxin to those cells to say, hey, cells, you need to get on those arteries and dilate the arteries. And if you can't do that, I'm sending this toxin here to warn you that I'm ischemic and I need more oxygen. My baby here is starving and the baby needs more nutrients. But what happens, instead of the cells actually taking the toxin and doing what it should do and dilating the cells, it goes the opposite direction. And we have vasospasms instead. And so it actually narrows the uterine arteries instead of dilating them. So the toxin causes decreased tissue perfusion. It's like a vicious cycle. So because we have inadequate vascular remodeling, we have decreased placental perfusion and hypoxia. And the placenta is an organ, just like the other organs in the body, and it's very vital. Uh, and when those endothelial cells, when they dysfunction, they cause vasospasms, which is going to cause decreased tissue perfusion. They cause increased peripheral resistance, which again causes decreased tissue perfusion, and they cause increased endothelial cell permeability, which causes decreased tissue perfusion. With this permeability, what's happening is that not only are we narrow and going through vasospasms with those uterine arteries, but now the plasma that's inside is seeping outside of the vessel inside of the interstitial space. And because it's seeping into the interstitial space, we're still losing what? Volume, right? And we're losing volume that's actually transported to the placenta because the mom is swelling. She's swelling in her ankles and her legs. With severe preeclampsia, the swelling is in her hands and in her face. So because of that swelling, we're losing vascular volume. Okay, we're good with that? Preeclampsia continued. So generalized vasospasms here. Generalized vasospasms is number 7 in your workbook. It's the process which results in poor tissue perfusion in organ systems, increased peripheral resistance and blood pressure, and increased cellular permeability, protein and fluid loss. Okay, that occurs, and the plasma volume is reduced. And when you reduce that plasma volume, you're reducing the amount of nutrients, there again, and oxygen that is transported to the placenta. This is the reason we can end up with babies that are born and they have intrauterine growth restriction because a woman has had preeclampsia during pregnancy. So these babies, even though they are full term, like 39 weeks, they actually are the size of a baby that would be closer to 32 or 33 weeks, and they're just in size, okay? And they can suffer gravely because of that. When we look at the assessment that we do for pregnancy-induced hypertension to determine if a woman actually is exhibiting signs and symptoms of pregnancy-induced hypertension, we ask her, do you have a headache? Do you have visual disturbance? Do you have epigastric pain or heartburn? And have you experienced any nausea, vomiting? And what we're doing is we're going through this list right here that's before you, trying to determine, do you see spots before your eyes at all, whether or not she's exhibiting symptoms as a result of the pathophysiology of pregnancy-induced hypertension. So the vasospasms and the decreased organ perfusion causes the hypertension. It also causes the uteroplacental spasms, which can result in the intrauterine growth restricted infant. It causes glomerular damage, which can increase plasma and uric acid and creatinine, and cause oliguria in the mom. It can actually lead to kidney damage. The cortical brain spasms is what causes her headaches and her hyperreflexia, for her DTRs to be +3 and +4 and lead to the seizure activity. And the retinal arterial spasms that occur will lead to her blurred vision. Okay, and she can have hyperlipidemia, and unfortunately it can damage the liver because of liver ischemia. It causes elevated liver enzymes, which leads to the nausea and vomiting and the epigastric pain because of the region it's located in, and the right upper quadrant pain because the liver is enlarging. And in fact, they typically try to rule out HELLP syndrome from fatty liver syndrome, fatty liver disease as well. So the intravascular coagulation that's occurring, it causes her red blood cells to be ligated or broken down a whole lot sooner than 120 days. It causes platelet adhesion, which can decrease her platelet count and lead her into DIC, which we'll talk about later. And then it can increase her factor 5, her factor 8 antigen as well. Now, the increased permeability and capillary leakage, it causes the proteinuria because of the glomerulus. It actually enlarges the glomerulus so that the protein can actually seep into the filtrate, and that's what creates that generalized edema. This edema can, of course, go to the lungs and cause pulmonary edema, sending the fluid there, backing it up to the lungs, which can lead to dyspnea. And then, of course, with all of the plasma leaking out, it's going to allow for the blood cells that are there to be elevated. So she has hemoconcentration, and that's going to automatically increase her hematocrit. Going into one of the major complications of pregnancy-induced hypertension is HELLP syndrome. And so they say that HELLP syndrome is for advanced nurses, and yes, it is, but you really can't really avoid knowing about it because some of the signs and symptoms that the woman has during preeclampsia actually alerts you to the fact that she is seeping into HELLP syndrome. And so you need to be aware of that so that you can make sure that you document it and you let someone know, hey, this is happening. Okay, so HELLP syndrome. HELLP syndrome is an acronym that stands for hemolysis for the H, elevated liver enzymes for the EL, and then low platelets for the LP. And it's based on laboratory diagnostics variants of severe preeclampsia and the liver dysfunction as a result of uh, the preeclampsia. It can be diagnosed as either partial HELLP or incomplete HELLP. And when it is, most of the time, it's undiagnosed. Okay, like 15 to 50% of the cases, people who have HELLP syndrome, they don't even have the severe symptoms of pregnancy-induced hypertension. or preeclampsia. They don't even exhibit the severe symptoms, and they can slip into HELLP syndrome. And in fact, a lot of the times the proteinuria is even absent. Okay? And it's very non-specific symptoms that will report, but when they do report, it's that the symptoms are worse at night, and yet they improve during the day. So you may have a woman who says she has really severe right upper quadrant pain at night, and then during the day it has dissipated. HELLP syndrome is associated with increased risk for pulmonary edema, acute renal failure, liver hemorrhage or failure, of course DIC, and then placental abruption, acute respiratory distress syndrome, sepsis, stroke, and fetal and maternal death. So it is very important that we key in on this. And because culture is important, HELLP syndrome is more common in the Caucasian population. All right, care and management. What do we do about it? What do we do about preeclampsia? Identifying and preventing it, because prevention is the best, is always the best cure. So we do a very thorough physical examination. We look for dependent edema, pitting edema. We check deep tendon reflexes. We check for clonus, and we're going to look at those. We look at the laboratory test. Of course, in the office, they can do a dipstick proteinuria, but however, the dipstick, as you know, is not a reliable test to actually for preeclampsia. Is not reliable, so they would really need to do a 24-hour urine, and so they'd probably have to admit this woman for overnight or give her the equipment to do a 24-hour urine specimen at home and then take that back to the lab. I think that they will do that now. So proteinuria is protein concentration of greater or equal to 300 milligrams in 24 hours, or creatinine ratio greater than 0.3. And by the way, electronic blood pressure measurements are not interchangeable with manual measurements. They're just not. So what we have to do is we have to focus on her blood pressures over a time. Because when she went to the office last month, they may have used a Dynamap. She had to go to maybe the med stop because she was having symptoms, and they used the Dynamap. And then she's coming to the doctor's office today, and the doctor wants you to do a manual blood pressure. So you have to look at the trends over time. And it's really key in on if her blood pressure is 160 over 110, this is the point to where the obstetrician will then send her to either a family practitioner or get another physician involved, because she's going to also require antihypertensive medications probably for an extended period of time. So some interventions that we can do if we have, so for the interventions for gestational hypertension and preeclampsia, that's without severe features, okay, that doesn't contain the proteinuria and the decreased platelets, etc. We can watch this mom and baby at home. And we want to, of course, deliver her as close to 37 weeks as possible. We don't want to deliver a preterm baby as a result of preeclampsia. And, of course, allow her to stay at home and do home management. And that's where the education becomes so important. When to tell her to return. If you have blurred vision, epigastric pain, nausea, vomiting, a headache that's unrelenting, those are the signs and symptoms you need to tell her that she needs to return. You unable to urinate, etc. Now, when she starts to diurese and her edema starts to decrease, that's a sure indicator that the resolution of her preeclampsia is coming to term. So we look for her to start to diurese and for her edema to start to decrease. What do we do for maternal and fetal assessments? There's going to be constant lab testing, certainly, because they want to know what her protein is, what her creatinine bun ratio is. They're going to assess for signs and symptoms throughout. They're going to do her blood pressure twice a week. She's to do fetal kick counts daily, and if her baby hasn't moved within a 12-hour period, she's going to alert somebody we probably have to go in and do a biophysical profile, and depending on what that result is, we'd have to do a C-section to save the baby. But she would have routine non-stress testing, and of course, with the non-stress test, we'd be able to see what the baby is doing as far as the fetal heart rate is concerned, whether there's any decelerations or whatnot. And activity restrictions, uh, there used to be, they would used to just put these women on bed rest and leave them there until around about 36, 37 weeks and then try to deliver them. But there's no evidence that supports that that is actually beneficial. In fact, the evidence supports that it is more detrimental to restrict their activity, and also it's more detrimental to restrict their entire salt intake. You may limit it, but you may not restrict it, because the babies need that sodium in order to develop neurologically. Okay, and if you put a woman on strict bed rest, it just gives her actual decubiti, because women who are pregnant, because they have all that extra fluid, are more susceptible to decubiti, just like the elderly. This is what pitting edema looks like. You probably have all seen pitting edema. This is how it's measured, and this is how it would be charted. And then here you're seeing reflexes here, reflexes for clonus. Here in letter F here is actual where they're looking for the clonus. I would put my hand a little bit closer here to the Achilles tendon, but the premises is that you're pushing dorsal flex in this foot, right? And then you determine if once you let go, if that foot taps back, it would show like a jerking movement to show that clonus was present. And anytime clonus is present and with hyperreflexia, then a seizure is pending. I think we have in your textbook on page 285, the reflexes. If there's no response, it's 0. If it's sluggish or diminished, it's +1. And that +1 is usually due to maybe the fact that they're on mag sulfate. If they're active or expected response, is a +2. A +3 would be if there's a more brisk than expected or slightly hyperactive. It kind of catches you by surprise a little bit. So when you're checking someone's reflexes, you're expecting for their leg to jerk or their arm to jerk. But when it catches you by surprise, that's how you kind of know, oh, that's hyperreflexive, because I wasn't expecting that. And then if it's very brisk and hyperactive with intermittent or transient clonus, is considered a +4. At that time, what you need to do is actually get prepared for seizure activity, and make sure that your surroundings are clear, your side rails are up, and that all of your safety precautions are in place. Okay. Would someone like to read the discussion? Miss Gilbert, can you still hear me?
I can hear you okay, Ms. Wimsatt.
Okay. All right, great. Thank you, Jamie. Would you like to read the discussion?
Sure. 37-year-old, 36-week G4P2 T0 P2A1L2 in labor woman has had a consistently high blood pressure varying from 152/94 to 168/98 since her teenage years. Her weight gain has increased 4 pounds in 1 week. She complains of throbbing headache and has edema in her fingers and face. Her latest urinalysis was +4 in dipstick in office. Biceps and patellar reflexes are brisk, +3.
Yeah, thank you. I appreciate that. So, to break down what her gravity is, she's been pregnant 4 times, but she's only delivered twice. Okay, and the the deliveries that she's had have been preterm. So she's delivered 2 preterm babies, and none of her babies have she taken to term. She's had 1 abortion. Um, probably spontaneous. So that counts for 3. So whenever, and then she has 2 children that are living. The way you look at your gravida para is the gravida is the number of pregnancies, and the para is the number of deliveries that she's actually had past 20 weeks gestation. And if you add up your term and your preterm and your abortions, then and your living, it should equate to 1 under the gravida if she's like pregnant now. I hope that made sense. All right, so we're going to discuss her plan of care, and it's really here on the next slide. What do you think she requires as far as her plan of care? Anybody? Here, let's go over here. She needs seizure precautions, don't you think? Because she's actually admitted to your labor unit, and she needs seizure precautions because she has reflexes that are brisk, that are +3, and she has a throbbing headache. She may need antihypertensive medications because her blood pressure is like 168/98. So what they're going to do for her is they're going to start her on magnesium sulfate. And magnesium sulfate is going to help to prevent any seizures because that's the reason we give it when we're talking about preeclampsia. Now, one of the benefits of it, or the side effects of magnesium sulfate, is that it also decreases the blood pressure. But the reason it is administered is actually to prevent the seizures, okay? So women who are pregnant, when they have an eclamptic seizure, we treat them with mag sulfate twice before they're given Valium. If they have a seizure the 3rd time, then we give them Valium. But the first go-to drug is always magnesium sulfate. Another side effect of the magnesium sulfate is because it decreases muscular activity, it's going to stop any contractions that she may have. So if you have a woman in labor, what she'll have to do is she'll also have to be induced and be started on Pitocin in order to start the contractions at a regular rate for her to deliver, because MAG is going to prevent that. Recently, evidence-based practice has started treating women who present with preeclampsia with an aspirin, and it's 80 milligrams of aspirin per day, and it may even be 2 of those depending on how severe her preeclampsia is. And what they have found is that that has actually helped to get these women closer to term and has decreased a lot of the severity of their symptoms by giving them that aspirin every day. Okay. Patient teaching, you would teach her about any medications that we administered for her, all of her safety precautions, reasons for fetal monitoring, because she would definitely have to have continuous monitoring, and explain the reason for her possible induction. And a woman like this who presents to the doctor's office or ER, she's definitely going to be admitted for observation. We cannot let her go home without 24 hours of continuous fetal monitoring, especially so that we can see what's going on with the baby, and also monitoring her for seizure activity. And the danger to the baby here is going to be fetal hypoxia, because of the decreased amount of oxygen and perfusion that's going to the placenta. And it can be so severe that it causes the baby to have acidemia, which would drop their pH well below 7.35, and then also the intrauterine growth restriction. If there's any indication on the fetal monitor or the biophysical profile that that alerts us to that baby has acidemia, she's going to be delivered right then, because the baby cannot survive if there's evidence of acidemia. Are there any questions?
Ms. Wimsatt,
Yes.
what is IUGR? I may have just missed that.
Okay. No. Okay. It's intrauterine growth restriction.
Oh,
So
right. Okay.
yeah, yeah. The baby's could be 37 weeks, but it's going to be the size of a 32-weeker. He just can't grow because it's not receiving not only oxygen, but it's not receiving nutrients.
If you have the time and the mental capacity to watch Maggie and Milo, she has an IUGR pregnancy. She gets magnesium. She gets preterm delivery. She gets magnesium twice. She gets steroid injections. Kind of goes through a lot of this about preterm. I recommend it, but again, I don't want to push it on anybody. But it goes through this whole situation too.
She sounds really interesting.
Right.
Yeah, because all of it kind of flows hand in hand.
Mm-hmm.
Once you start down that hill, it
Mm-hmm.
just kind of spirals
Right.
and
And it's not due to eclampsia. It's due to trying to prevent her to go into preterm labor.
oh, gotcha, gotcha.
So that's why she gets the magnesium.
Okay, yeah, yeah.
Yeah. Yeah, we said that video was not required, but it is great. But you will get everything else elsewhere. So if this seems like a duplicate, that's the intention, because I don't want to force someone to watch that Maggie and Milo video if you can't handle it. Okay.
Yeah, yeah, it's really good to know that too because we use magnesium sulfate. As I said, remember magnesium sulfate decreases uterine activity, so that's the reason it's used to help preterm labor because it stops contractions. So here's another case study with Olga. She's 38 years old and she's a gravida 3, para 2. She's 35 weeks now. She has preeclampsia. So she presents at 35 weeks to the L&D unit from the office. And she was treated with mag sulfate, but it resolved during her postpartum period. She complains of headache, nausea, vomiting. Her headache is in the frontal lobe behind her eyes for 2 days. It's rated 8 out of 10 pounding. She denies heartburn. Fetal kick count is 10 per hour, so the baby looks good. But she's short of breath with exertion. And she has bilateral rails in her basis. And her blood pressure is 170 over 110. Her DTRs are +4. She's got 2 beats of clonus. And she's got facial and hand edema. She's also, if you've picked up on the shortness of breath with exertion, she's going into pulmonary edema. Because look at how much weight she's gained in 1 week. She gained 6.6 pounds in 1 week. That's just way too much weight. And all of this weight gain here is water weight. It's excess fluid from the preeclampsia and the edema. So she's in dire straits there and can definitely have a seizure with the 4 plus and the clonus. But even after the seizure, we've got to be concerned about the pulmonary edema that's going on. This is if we were to do a simulation, but so what we would need to do here is she needs to um, have her be turned on her side, have a pillow under one shoulder. You would call for assistance. You have suction at the head of the bed, and it's already set up, especially in labor rooms and in the postpartum room, too, at the head of the bed in case somebody has a seizure. There's like a suction gomco. There's the stabilizing movement in a draw sheet or a blanket to prevent injuries. She would need a non-rebreather face mask for 10 liters of oxygen after the convulsion. We would monitor her for fluid overload and start magnesium sulfate at a bolus of 4 grams to prevent the seizures and monitor vital signs in fetal heart tones and contractions and her perineum after delivery. Now, here's the thing. If a woman has a seizure and she is actually pregnant, 9 times out of 10, the baby is going to try to get out of that womb, his or herself, and she will go into labor. And most of the time, you'll find that the baby is either crowning on the perineum immediately after a seizure or actually has delivered during the seizure. because what does the uterus do? It clamps down and pushes the baby out, right? If she has a seizure and that uterus clamps down really hard, it can therefore cause a precipitous delivery. And that's not good for the mom, and it's not good for the baby. And if the baby's not out and we have adventitious fetal heart tones, she possibly would have to, once she's stable, have a C-section just to save the baby. Now, with magnesium sulfate, we position her on her side in order to administer the magnesium sulfate, and that is so that we can have adequate perfusion to the placenta so that she's not laying on those great vessels causing supine hypotension. And especially because magnesium also is going to cause hypotension, we prepare a solution and administer it with an infusion pump. So MAG is a medication that typically always has to be delivered with an infusion pump, but it typically also has to be delivered usually in the labor unit. If someone's going to be on MAG, they will transport them back to the labor unit unless there's no room available. And if there's no room available, they'll put them with a one-on-one nurse in a postpartum side. The piggyback solution of 40 grams of MAG and like 1,000 cc's of lactated ringer solution with the infusion controlled pump device, the loading would be 4 to 6 grams over 15 to 30 minutes, and the maintenance dose after that is going to be 2 grams per hour according to the unit protocol and specific physician orders. And the way that that magnesium is administered is that you have the pump tubing, which is regular tubing, and it's extended tubing. That's your MAG. And then you have a regular lactated ringers also hanging, which is your primary bag, and it has anesthesia tubing. The anesthesia tubing is going to the mom's IV port, right? That's her main port. And the piggyback is the magnesium, which would be actually infused at the lowest port closest to the site, so that if we ever had to bolus her with fluids because of an emergency, we're not bolusing her with MAG. Signs of magnesium sulfate toxicity would be flushing, diaphoresis, hypotension. She'd have decreased DTRs like +1 or lower, and you would see like a change in her DTR. So if she had +2 continuously and then all of a sudden she drops to +1, that's a significant change. Okay, respiratory depression, her respiratory rate would drop below 10. She'd have decreased urinary output, and anybody who is on magnesium sulfate, will have a Foley catheter, and their urine will be checked every hour. We also will do MAG levels, and her MAG level, if it is greater than 8, running towards 9, and she has slurred speech at all, then that's also considered MAG toxicity. Here we have maternal and fetal assessments. I don't know that you can see that, but what it is a MAG sulfate flow sheet. So when a person is on a drip like this, you not only have your regular assessment, but you have to go in every hour and complete this magnesium flow sheet. And you would look for her sensory and her pain, check to see if she was lethargic, alert, if she has a headache, visual disturbances, epigastric pain, her respiratory, her breathing was labored or non-labored, what her rate was, if she's on O2, what her O2 saturation is, and she would be on a pulse ox, but you would monitor if she was on with oxygen or without. Of course, we're going to look at the fetal status there and her cardiovascular status, her deep tendon reflexes, her urinary output, clonus, the MAG levels, and her IV site would be checked, and any other type of medication administration would be listed here on this flow sheet. Signs that you would report to the physician would be if her blood pressure remained consistently above 160 over 110 while on the MAG. Okay, it may have been that prior to magnesium, but if we're remaining there, there's a problem. If her respiratory rate is less than 12, if she has brisk VTRs or clonus, if her urinary output is less than 30, if her MAGS levels are greater than 8. We're also going to look at her platelet count. If her platelet count is less than 100,000, creatinine greater than 1.1, uric acid greater than 7.0. And then, of course, she's going to have her liver enzyme panel done. And if it's elevated, that would be a significant lab to report. Fibrinogen, fibrin split products, and partial thromboplastin time, if those are present. And then, if they're elevated, excuse me. And then the prothrombin time, if it's greater than 15 seconds. All of those would be reportable conditions when a woman is being treated with magnesium sulfate, because it's an indication that she's going into HELLP syndrome and that her conditioning is worsening and that the MAG is ineffective and that we need to get the baby out so that hopefully we can end this cascade of events. Any questions about that? We're going into hyperemesis gravidarum.
Miss Wimsatt.
Yes.
So I was just thinking about this. Can magnesium be administered if someone has a seizure? I know you're talking about preventing one, but what if they actually have one? What do they do with that?
They still administer magnesium.
Okay.
Yeah, they still administer magnesium. And hopefully she has an IV site, because we can administer magnesium sulfate IM, like with a 10-gram loading dose, and give her 2 separate injections of 5 grams in each site. And hopefully it's in the ventral gluteal site. But it's very painful, and of course, if you do that, you'd have to mix that with an anesthetic in order to give it, because it has to be given deep IM. But yes, when you give magnesium sulfate to prevent seizures. If she has a seizure, you give magnesium sulfate. If she has a second seizure, you give magnesium sulfate, and it's not until after the second seizure that they will actually give this woman Valium to control her seizures, because we have a baby on board, and that's the issue. If we give that baby Valium, we're going to knock that baby completely out, and 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 that's the issue. Now, if she's postpartum, they're going to try to treat her with magnesium sulfate, but they may give her Valium a little bit quicker during the postpartum period than during if she has a baby on board. Does that make sense? Yes? No?
Yes, ma'am, that makes sense. Thank you.
Okay, you're welcome. Okay, so hyperemesis gravidarum, and hyperemesis gravidarum is number 11 in your workbook. It's excessive vomiting accompanied by dehydration and electrolyte imbalance, ketosis, and acetonuria. The high levels of estrogen is really where it comes from, or human chorionic gonadotropin. And transient hyperthyroidism or gastric dysrhythmias, all of those uh, will cause this phenomenon of hyperemesis gravidarum. And the clinical manifestations are the woman has significant weight loss. I mean, right when you first become pregnant, you will see like a 1 to 2 to 3 pound weight loss, probably right before the diagnosis of pregnancy. But then after that, the weight should start to increase. But these women, they continue to lose weight. They have severe dehydration, which is shown by all of their dry mucous membrane. You know, they have hypotension, they have tachycardia, tachypnea, hyponatremia, and of course, hypokalemia, because they're constantly urinating here, and they have these dry mucous membranes. This woman needs to, sometimes I have seen them so bad to where they would have to put this woman on TPN in order to sustain her and the pregnancy, because it was so severe. But now we have a specific treatment where we use vitamin B6, And also, we can use Unison to help give her some rest, because she's constantly throwing up her toenails. And then we have this medication called Diglesias, which is a single dose combination, and it provides delayed release effects. It's very expensive, and there's no generic form available for it. And they typically will give this during the first and the second trimester. They will not usually, and that's usually when this occurs, it's like during the first and second trimester. And this medication is very effective at treating hyperemesis gravidarum, but it can be a tetragen if it's given like during the third trimester. The safety with the other medications such as Phenergan, Compazine, Tygan, Zofran, uh, they have not been proven, but in the past we did treat them. We treated them, alternated them with Phenergan, okay, and Tygan. We would just like alternate them so that they didn't get too much Phenergan. And like within the last 8 or 9 years or so, we've treated them with Zofran. And I don't say we as in me. I'm not a physician or a midwife. I mean that was the treatment protocol at that time. But Reglan was not used because it accelerates gastric emptying, so it actually made their condition worse. And of course, we would limit the number of visitors that these women had, make sure that they did not get upset, because it was also correlated with a psychological component to where if stress was involved, it made their condition worse. Now let's go into hemorrhagic disorders. With hemorrhagic disorders in pregnancy, they are considered medical emergencies because the woman, of course, is bleeding, and maternal blood loss decreases oxygen carrying capacity, which, of course, is going to increase her risk for hypovolemia, which is very dangerous for a mom and a baby, anemia, infection, cause preterm labor, and even preterm birth. And it will adversely affect the oxygen that's delivered to the fetus. And so some of the fetal risk factors would include blood loss or anemia, hypoxemia, hypoxia, and even anoxia, and then preterm birth. If you're not getting any blood, you're not getting any oxygen, and that just makes sense. And if there's no oxygen there, then death will ensue. And that's the reason the hemorrhagic disorders are so dangerous. And here we're talking about types of miscarriages. And miscarriages are in your textbook on page 299, and they are all considered in medical terms abortions, even though they are spontaneous. They're considered still abortions, and there's several different categories. There's the threatened, inevitable, incomplete, complete, and then the missed. Here are the dangers here. What we do if a person is suffering from a miscarriage is we do resolve through sharing. And resolve through sharing is where women are allowed to heal together, and in the hospital, depending on the gestation, we will actually dress dress the babies. We will take locks of hair and any type of memorabilia we can, and it goes inside of a book for the mom so that she can have that to remember her baby by. Okay, so let's start with miscarriage, which is number 12 in your textbook, in your workbook. It says it's a pregnancy that ends as a result of a natural causes before 20 weeks of gestation or less than 500 grams birth weight. And it is termed early pregnancy loss if it occurs between 12 weeks gestation, and late pregnancy loss if it occurs between 12 and 20 weeks gestation. So if it's before that 12 weeks, it is actually early pregnancy loss. Okay. Missed miscarriages, these are sometimes the worst. That's pregnancy in which the fetus has died, but the products of conception are actually retained in the utero. for up to several weeks. And yes, the woman would be allowed to go home to see if the products of conception would pass naturally, but after several weeks, we have to check her blood clotting factors and monitor those until the uterus is actually empty. And of course, there's a risk for DIC if the fetal demise remains in utero after 12 weeks or the products of conception remain longer than 5 weeks. So that becomes a danger to the mom. And then the recurrent miscarriages are very sad because it's usually 3 or more consecutive pregnancies uh, that result in a miscarriage before 20 weeks of gestation. And if that happens, we really have to determine what's causing it. Is it because of Rh incompatibility? Is that what's causing it? Is the mom Rh negative? Because after any type of miscarriage, uh, the woman has to have ROGAM if she is Rh negative to help to prevent this from happening again. So maybe that's part of the reason that it's occurring. Is it because she has an incompetent cervix? Is that the reason? If so, then we need to do a cerclage to remedy that issue to make sure that that's not the case. So septic miscarriages is the management here. We'd have to manage septic shock. And what happens here is that immediate termination of pregnancy by method appropriate to the duration of the pregnancy needs to occur if she shows any signs of sepsis. Okay? We would do a cervical culture and sensitivity studies are usually performed. She would be given broad spectrum antibiotic therapy, several like Rocephin, gentamicin, Flagyl, ampicillin, of course, and treated for septic shock if necessary. And as I said before, ROGAM would be provided for all Rh negative clients. Cervical insufficiency could be one of the reasons for miscarriages here, and that would be where there's passive and painless dilation of the cervix during the second trimester, leading to recurrent preterm births during the second trimester in the absence of other cases or other causes. So the etiology is where they have an impaired cervical strength. And that could be because of a LEAP surgery or a loop surgery where they may have had uh, additional cells or suspicious cells on their cervix, and they had to go in and take an actual piece of the cervix itself to determine if she had cervical cancer. That can precipitate a cervical insufficiency. Okay. The diagnosis would be OB history of preterm births or late miscarriages. And the management is that we would do a cerclage. And a cerclage is a procedure that involves placement of a suture around the cervix, actually beneath the mucosa. Okay, it's like a purse string suture to constrict the internal os of the cervix, and it's called the McDonald's technique. When you're looking at the cervix, and I think we have the cervix on the next picture, so I'll show you when we get there. But they use this cerclage prophylactically and therapeutically or as a rescue procedure after cervical change is identified. Maybe we can save or prevent a miscarriage if we can get that cerclage in time. The follow-up care when a woman has a cerclage is to closely monitoring the pregnancy for the preterm labor and infection. And this is what she would report. Any strong contractions less than 5 minutes apart? Absolutely. Any cramping? Any low back pain? Any premature rupture of membranes? Okay, severe perineal pressure. So it's very important that she would report the contractions, the cramping, and the low back pain, and any fullness that was felt within her thighs. And then, of course, we would use resolve through sharing as a management of grief or prematurity if ineffective. This is what the cerclage procedure looks like, and it's around the internal os is what I was going to try to key in on. So here is the external os, which is the part of the cervix between the vagina and the cervix, and then here's the internal os. And this is the portion of the cervix between the cervix itself and the uterus. So right there would be where the mucus plug would be. It would be after this purse string suture. And that would help to prevent any type of ascending infections too from reaching the membranes after the procedure was done because of its placement. Here's a question for you. A pregnant woman is being discharged from the hospital after placement of a cerclage because of a history of an incompetent cervix. Discharge teaching should emphasize which of the following? What do you think? Okay.
I
Yes.
say D.
Yes. Thank you so much. Absolutely. Absolutely. So here's the reason why the we emphasize the preterm labor. Could you imagine having a suture around the cervix that prevents delivery, and then having all of those signs of preterm labor and preterm labor actually trying to take place? That would split that cervix, because if the baby's going to come, the baby would be strong enough to rip that suture out of that cervix. And that's the reason why it's so prevalent. Now, I have seen where people came in to have cerclages because they were having difficulty, and they were having preterm labor, and they had an incompetent cervix, etc. And then they go home and they come back in and they actually have to be induced for labor because it's that effective. Right. Ectopic pregnancies. Ectopic pregnancies is number 17. Is a pregnancy in which the fertilized ovum is implanted outside the uterine cavity, most often in the uterine tube. The incidence and etiology is like it occurs in 95% of intrauterine within the fallopian tube, usually in the ampulla section. And other sites include the ovaries, abdominal cavity, and the cervix. Here's a picture. They can actually have an implantation right here on the fimbriae, right, that are going to sweep the zygote into the uterine tube. And what happens is typically the woman may have endometriosis, where she has lining, that intrauterine lining, in other areas outside of the uterine cavity. So the zygote can implant there and try to grow. That's one reason. And then what causes it to occur most often here in the ampulla is maybe infections within the tube, or narrowing of the tube, because not every person is built the same. There may be some type of genetic reasons why one of her tubes is more narrow than the other. And also it could be because of adhesions from sexually transmitted infections. It could be because of previous uh, DNCs, dilation and curettages, from maybe elective abortions, etc. But when an ectopic pregnancy occurs here on the cervix, it is extremely dangerous. And it is extremely dangerous because the cervix is very vascular. So if it occurs there, it can start hemorrhaging and cause severe hemorrhage, okay, on the cervix. Also, it's very dangerous if the tube were to rupture. That is another danger of the ectopic pregnancy, is the rupturing of the tube. Okay. The majority of the here's what she would need to what the mom would need to report. Typically, they have abdominal pain. They may have a delayed menses. They have abnormal vaginal bleeding or some type of spotting, and they have abdominal pain in most all cases. Typically, there's a dull lower quadrant pain on one side, typically the side where the tube is affected. And this discomfort can actually progress from a dull to a colicky pain, and when the tube stretches, it actually is very sharp and a stabbing pain. Okay? And it progresses to a diffuse, constant, severe pain that is generalized throughout the lower abdomen. So as her pain, as the zygote increases in growth, the characteristics of her pain will change. And that's something to key in on if you have someone calling on the telephone and saying, well, last week your pain was dull and colicky, right? And then this week, or you're saying that your pain is sharp and stabbing. That's something that you pay attention to. That's not that the woman has issues with knowing what her pain is. And hopefully she gets there before her tube ruptures. If the tube was to rupture, it could be massive hemorrhage. She may lose that tube on that side because they would have to cut and cauterize, but yet and still she may still have be able to be to conceive with the tube that she still has that's viable. Clinical manifestations: abdominal pain, delayed menses, abnormal vaginal bleeding. What they would do to diagnose it is they would use a quantitative HCG levels and a transvaginal ultrasound. The transvaginal ultrasound is going to show us whether or not there's anything in the intrauterine cavity. And if there's nothing there, and yet we have high levels of human chorionic gonadotropin levels that says that she is pregnant, then you know that that pregnancy exists, but it's no longer in the, but it's not in the uterus. Okay. What would they do to treat her? Is they will treat her with methotrexate, and methotrexate is like 50 milligrams IM or 1 milligram per kilogram. And there's a box in your textbook that tells you about patient teaching for people who are using methotrexate, like don 2 pair of gloves, do not expel the air from the syringe to prevent aerosol in methotrexate, and no analgesics. She shouldn't use any analgesics stronger than acetaminophen and avoid masking the tubal rupture, because if she does, then she may not be able to feel that tubal rupture. And contact her healthcare provider immediately for severe abdominal pain, sign of impending or actual tubal rupture. Of course, they're going to do surgery. The surgery we call the salpingectomy, where they would go in to remove that tube. Her follow-up care would be weekly HCG levels, and then she may have to have future fertility drugs and contraceptions. All right. Are you guys doing okay? I was trying to go fast. I don't know how long I have. I don't know if I'm out of time or not, but I was trying to go really, really fast here. Um, let's talk about the hydatiform mole. A hydatiform mole is it's actually where it's only one DNA present inside that ovum, for instance. So number 18, it says, is a group of pregnancies related to trophoblastic proliferative disorders without a viable fetus that are caused by abnormal fertilization. It includes hydatiform mole, invasive mole, and choriocarcinoma. So the complete hydatiform mole, which is 19, is a disorder that results when an egg without an active nucleus has been fertilized. The egg has no nucleus, but yet it's been penetrated by a sperm and fertilized. The partial hydatiform mole is a disorder that results when two sperm fertilize an apparent normal ovum. Here's a diagram. What you have here is that the egg was empty. The egg was empty here, and so when it was fertilized here, we have 46 X and X because two sperm went in there, and this is the result of all paternal DNA. It's actually, you have these grape-like vesicles that will continue to grow, and that's the hydatiform mole, and it exhibits choriocarcinoma, and that's the reason why we have to, and it can lead to that, in fact, and that's why we have to be so careful with this woman afterwards. So the fertilization of an egg in which the nucleus has been lost or inactivated, and that sperm duplicated itself. Here is dispermy, and dispermy is where you have an egg here, and inside this egg there is a nucleus. There's 23 X chromosomes, but it's being penetrated by 2 sperm. Now usually there is a zona peninsula surrounding the ovum that prevents this from happening, but sometimes they fail. And so we end up with diandry, where you have 2 sperm inside with an ovum, and that's going to produce 69 XX and Y. It is not compatible with life, so it leads to a hydatiform mole. Clinical manifestations is blood loss. They have grape-like clusters, and it's dark red blood. The mom will suffer from severe anemia, and she may have pregnancy-induced hypertension as a comorbidity. In fact, the pregnancy-induced hypertension, though, will actually exhibit itself a lot sooner, like right at 20 weeks, than it would in a normal person who had pregnancy-induced hypertension, and it may be a lot more severe. The diagnosis for a hydatiform mole is with a transvaginal ultrasound, and they will also do serum HCG levels. When they do an abdominal ultrasound, what they will see is like a snowstorm pattern in the place, along with an embryo or a fetus, if there is a fetus present with this hydatiform mole. Okay. And the tropoblastic tissue will always secrete the human chorionic gonadotropin hormone, and that's what we will use to determine whether or not she has developed cancer after we have removed this hydatiform mole. Management is suction and curettage, resolved through sharing. Um, Given her birth control, she will have to have birth control because she will not be able to become pregnant for an entire year afterwards, because we have to monitor her weekly HCG levels for an entire year to ensure that she doesn't have choriocarcinoma, and ROGAM if she's Rh negative. And this woman will have frequent pelvic examinations as a result of that. Hello, did you have a question? So, Miss Gilbert, am I out of time?
We usually finish around 12:30, so I would like you to get through placenta previa and the one after that. Let me pull it back up.
Get to the part 2?
Mm-hmm.
Okay, I'll try. Okay. So
Placenta and abruption.
Okay. Late pregnancy bleeding. With the placenta previa, the placenta is actually implanted in the lower uterine segment, which is near or over the internal cervical os. And the classifications here is you can have a complete placenta previa, which is where the implantation of the placenta is in the lower uterine segment, totally covering the internal os, and a C-section there is required. One of the telltale symptoms is that it's painless, bright red bleeding because of where it's located. The marginal placenta previa, though, is implantation of the placenta in the lower uterine segment. And what we call that is like a low-lying placenta previa, because during like the first and second trimester, the woman can have a low-lying placenta previa, but then during the third trimester, as the uterus grows up and out, it moves away from the cervical os, and so then that's no longer a problem because it's no longer covering the cervical os. This is a picture here. As you can see, this is a complete previa where the placenta completely covers this cervical os, and as the woman dilates, it rips away from the placenta, and that's what causes the bleeding. And over here you can see the low-lying that can actually move up and away during the later stages of pregnancy. The placenta previa, the painless bright red vaginal bleeding, maternal and fetal outcomes. Typically, it's an abnormal placental attachment when it comes to the mother. So postpartum, she may have an accreta, increta, or percreta, which will lead to excessive bleeding. And with the fetal risk, it includes actually malpresentation. It can have her in a transverse lie. See how this baby is positioned there?
Miss Wimsatt,
Yes, ma'am.
can you speak up a little bit more? I'm having difficulty hearing you.
Okay.
That's better.
Should I start on this slide?
Yeah, sure.
At the top.
Sorry.
Okay. With the placenta previa, the incidence and etiology. So the painless bright red vaginal bleeding, that's a telltale sign. But maternal and fetal outcomes, she will have an abnormal placental attachment. So the mom could have accreta, increta, or percreta, which would lead to excessive bleeding afterwards. And the babies, the risk would include the malpresentation. See how I put this picture here of this baby in almost like a transverse oblique position there, because of the placenta being where it's located. And then, of course, preterm birth and fetal anemia. We do a Klein-Hyde-Beckett test to determine if it's the baby who's bleeding or if it's the mom who's bleeding. And if it's a fetal bleed, then we pretty much have to get that baby out of there pretty quick. And also, it's related to congenital anomalies, primarily because of the way this baby is positioned. When the baby is in utero, it has to be able to have buoyancy and move, and if not, then the limbs may be shorter than expected. With the placenta previa, the diagnosis and medical management is the standard diagnosis is actually a trans-abdominal ultrasound. And medical management is like we want to observe her, put her on observation and bed rest so that she's not bleeding. She's not on strict bed rest. She's on bed rest with bathroom privileges. And no vaginal or rectal examinations, absolutely not. In fact, before you ever do a vaginal examination, you have to know where the placenta is so that you don't arbitrarily stick your fingers through the placenta. That would be awful. Home care, she's going to do fetal kick counts, and they will actively manage her. If she says that she is bleeding, then she'll come back in, and then they have to do a cesarean birth with low vertical uterine incision. You know, they can't do the Fantasteal where they cut across with the bikini cut if there is a placenta previa, because they would cut into the placenta. Now, with abruptio placenta, abruptio placenta is where there's a detachment of part or all of the normally implanted placenta from the uterus, and it occurs in the decidua basalis, that's on the mother's uterine lining, after 20 weeks gestation. So what I'm saying is that it's just like a scalping, uh, pulling her scalp back, but it's actually inside of her uterus. So when you rip the placenta away from the uterus, that's the simile of it. It occurs in 1 in 80 or 1 in 250, which is too many for me. The etiology is maternal hypertension. When a woman has hypertension, it's like a hose pipe that has been tied off with a knot, and you have excessive pressure coming through that pipe, and that pressure can actually pop or move or explode the placenta away from her lining. Cocaine. Cocaine causes vasoconstriction. So cocaine, it can actually cause that placenta to detach. Trauma, uh, car car accidents, seat belts. Oh my goodness, a seat belt. And if she has the factor V Leiden. Now, risk factors: cigarette smoking, premature rupture of membranes, and multiple gestations. Cigarette smoking, because nicotine also causes vasospasms on the uterine arteries and can push the placenta away. The expected findings are sudden onset of intense uterine pain with or without dark red vaginal bleeding, board-like uterus, and they have a covillard uterus, and that all that means is that there's blood between the uterine muscle, and you see this blue and black bruising on the outside of her abdomen. She'll also have signs of hypovolemic shock because of the massive blood loss. We're going to do an H&H, clotting factors will be decreased, and we're going to do a Clyde-Hyde-Beckett test. A Clyde-Hyde-Beckett test determines if it's a fetal bleed, it's pink, and if it's a maternal bleed, it's actually red. So here are some classifications of the placenta previa or placenta abrupti. The grades here, if it's mild, she's going to have total blood loss of less than 500. The color of the blood is dark red. The shock, rarely none. Coagulopathy, rare none. Uterine tonicity, how toned our uterus is, normal. Tenderness, usually absent. And the fetal heart effects, they're usually normal. We've seen babies delivered, and then afterwards they look at the placenta, and when they look at the placenta, they'll see a necrotic portion at the cotyledons when they're expecting the placenta, and they'll say, oh, she had a mild abruption. So it's not even noticeable. The baby may have had some uh, fetal heart rate decelerations, but other than that, we didn't even know. But when it comes to all the way over to the severe, there's greater than 1,500 milliliters of blood loss. There's dark red. There's sudden profound shock, DIC. Her uterus is technic-like and board-like. She's in agonizing pain, and the baby has abnormal fetal heart tones or even a fetal demise is possible, which is awful. Here is abruptio placenta. There's the partial separation where you have the concealed hemorrhage, and then there's the partial separation there where you have the apparent hemorrhage, and the complete separation where there's concealed hemorrhage. The reason it said with or without dark red bleeding is because you can have a partial separation and the hemorrhage is concealed and not coming out of the vagina, but yet she still has an abruption. And in your textbook, you'll see that they have like the different types. They have the subchorionic, which is between the placenta and the membranes. That's where she separates. The retroplacenta is between the placenta and the uterine wall. And then the preplacenta is actually a separation between the placenta and the amniotic fluid, is where that separation occurs. What would they do for her is they're going to do an H&H, coagulation factors, cross and type match, Klein-Heidt-Beckett, indwelling catheter, and monitor her for DIC, which is a pathological form of clotting that is diffuse and consumes large amounts of clotting factors, causing widespread external or internal bleeding, or actual both. And our goal here is for her to have a vaginal delivery. I know that sounds crazy, but if it's mild or moderate, she should have a vaginal delivery. If it is severe, she's definitely going to have an emergency C-section. And the C-section must be done with caution with women who have severe or uncorrected coagulopathy, because it can result in uncontrollable bleeding. And the possible fetal outcomes here would be a neurological deficit, okay, cerebral palsy because the baby's lost a lot of blood, a lot of oxygen. Sudden infant death syndromes are all greater in newborns following an abruption. And fetal survival is related to the size of that hemorrhage. And because a lot of this can sometimes happen during a car accident, that's going to be what we'll cover, or during what you'll cover during the part 2. Okay, that's where you wanted me to reach, and it is 12:30. I hope you all enjoyed the presentation,
Yes.
and I'm so sorry. I would have gone faster, but
No, you're fine.